Hi class, this is video number 2 for endocrine system. So for this video we are going to discuss chapter 37 and 38. So I am going to pull up the PowerPoint, chapter 37. And chapter 37 is about thyroid gland and parathyroid gland. Chapter 38 is about insulin. So 37, let's do 37 first, thyroid and parathyroid agents. So, thyroid gland, as you see, it is situated in the neck. And parathyroid glands are the 4 poles of wisdom right on the top of the thyroid gland. What are the secretions of thyroid gland? T3, T4, and calcitonin. So, the actions of thyroid gland produce two T3, T4. T4 is also called as tetraiodothyronine, also called as levothyroxine. And then T3, triiodothyronine, or also called as leothyronine. Okay, so these are made from iodine. That's why iodized salt is good for patients who have thyroid disorders, because these T3 and T4 are based on iodine. Alright. Functions of thyroid hormone: regulate the rate of metabolism. It affects the heat production and body temperature. It affects the oxygen consumption, cardiac output, and blood volume. It affects the enzyme system activity. It affects the metabolism of carbohydrates, fats, and protein, and it regulates the growth and development of the body. Hyperthyroidism could be underactivity, and hyperthyroidism will be overactivity. So hypo means less amount of thyroid production. Hyper means high amount of production. So when there's less amount of production, hypothyroidism, absence of thyroid gland, lack of sufficient iodine in the diet to produce the needed level of thyroid hormone, lack of sufficient functioning thyroid tissue due to tumor or autoimmune disorders, lack of thyroid releasing hormone related to tumor or disorders of hypothalamus. Most common issue with thyroid function. Hyperthyroidism. Hyperthyroidism is when thyroid produces a lot of thyroid hormone. The condition is also called as Graves' disease. And signs and symptoms: increase the body temperature, tachycardia, thin skin, palpitation, hypertension, flushing, intolerance to heat, amenorrhea, weight loss, and goiter. Replacement of thyroid products. So sometimes when we don't have enough thyroid hormone, when the body's not producing enough thyroid hormone, we replace it by medications such as Synthroid, which is technically, what is it? It is an artificial product, the levothyroxine, Synthroid. Alright, synthetic salt of T4. Thyroid armor. It is prepared from the dried animal thyroid gland, and it contains T3 and T4. Then synthetic salt of T3, and then synthetic preparation of T4 and T3 in a standard 4:1 ratio. So technically these are synthetically prepared T3 and T4. What is the action? They will increase if you give them thyroid hormone. What is their function? Their function is to increase the metabolic rate of the tissues. What is it that will increase? It will increase the oxygen consumption, respiration, heart rate, rate of fat and protein and carbohydrate metabolism, growth, and maturation. Indications: why do we give it? We give it as a replacement therapy for hypothyroidism. Pituitary TSH suppression in the treatment of euthyroid goiters, management of thyroid cancer, thyrotoxicosis in conjunction with other therapy, also called as myxedema coma. So myxedema is low amount of thyroid hormone. Myxedema coma, excessively low. So excessively low, it will cause myxedema coma. Pharmacokinetics: absorption in the GI tract, and it binds to serum proteins, eliminated in the bile, and does not cross the placenta. Contraindications: when do you not give these medications? When a person is allergic to these medications, thyrotoxicosis, acute MI, caution with lactation, and also with patients with hypoadrenal functions. Adverse reactions, it could give skin reactions, symptoms of hypothyroidism, cardiac stimulation, CNS central nervous system effects. Drug-to-drug interactions, don't give them with theophylline, digitalis, oral anticoagulants, and cholestyramine. Whenever you give any medication, always check history and physical. Know the allergies, whether patients lactating, any kind of baseline disorders such as Addison's disease, acute MI, heart disorders, complicated by hypothyroidism, thyrotoxicosis, and skin lesions, orientation and effects, baseline pulse, blood pressure, electrocardiogram, respirations, adventitious lung sounds, and thyroid function tests. So do baseline checking of general body examination before we give medications. Examples, levothyroxine is also called as Synthroid, which is the replacement therapy for hypothyroidism. All right, actions. What is the action of it? It will increase the metabolic rate of the body. All right, metabolism. It could be given IV, and it peaks. IV medication will peak in 24 to 48 hours. Onset is 6 to 8 hours. But PO medication is slow. It peaks in 1 to 3 weeks, and its duration is 1 to 3 weeks. Question number 1. Please answer the following statement, true or false. The hormones, parathyroid hormone and calcitonin, work together to maintain a delicate balance of calcium levels in the body and also to keep calcium levels within the normal limit. True. They work hand in hand. Renal tubular phosphate reabsorption is balanced by calcium secretion into urine, which causes a drop in serum calcium, stimulating parathyroid hormone secretions. The hormone parathyroid and calcitonin work together to maintain the delicate balance of serum calcium levels in the body to keep serum calcium levels within the normal range. So they work together hand in hand. They're like brother sisters. Okay, anti-thyroid agents. Anti-thyroid agents, when there's too much thyroid hormones, we have to give them something to cut it down, right? So what are those? Those are thiamides or iodine solutions. So thiamides prevent formation of thyroid hormone within the thyroid cells, lowering the serum level, partially inhibit the conversion of T4 to T3. Iodine solutions, high doses, block the thyroid function. Indications: hyperthyroidism. Pharmacokinetics. They're well absorbed from the GI tract, concentrated in the thyroid gland, and some excretion detected in urine. Iodine solution, rapidly absorbed from GI tract, widely distributed throughout the body fluids, excretion through the urine. Remember, all of them are excreted by kidneys. We check for allergies, pregnancy, and lactation. Antithyroid agents, number 3. Adverse effects. They could cause severe thyroid suppression. They could cause hypothyroidism, because they're slowing down the thyroid function. Drug-to-drug interaction. We try not to give them with oral anticoagulants, theophylline, metoprolol, propranolol, and digitalis. Iodide solutions, anticoagulants, theophylline, digoxin, metoprolol, and propranolol. Access. Remember this part: whenever we are giving any medications, we always check for the baseline disorders. We check for allergies, pregnancy, lactation status. We check whether they have any liver dysfunction, pulmonary edema, pulmonary tuberculosis. We check for skin lesions, orientation and AFAC, baseline pulse rate, so vital signs, and the cardiac functions, and thyroid function test. So strong iodine products, which are adjunct therapy for hyperthyroidism, and then methimazole, which is treatment for hyperthyroidism. Okay. In which of the following ways does the thyroid gland use iodine? To stimulate the production of TSH, to produce thyroid hormone, to regulate parathyroid hormone, to destroy the part of thyroid gland. To produce thyroid hormones. Thyroid gland uses iodine to produce thyroid hormones that regulate body metabolism. Control of thyroid gland involves an intricate balance between thyroid stimulating hormone, thyroid releasing hormone, and circulating levels of thyroid hormone. Parathyroid dysfunction. Parathyroid, those smaller glands, they produce parathyroid hormone. Hypoparathyroidism, hypo means less amount. The absence of parathyroid hormone, it is most likely to occur with accidental removal of parathyroid glands during thyroid surgery. And hyperparathyroidism is excessive production of parathyroid hormone can occur as a result of parathyroid tumor or certain genetic disorders. Now, calcium is controlled by the body through parathyroid. So parathyroid glands are like situated just those four poles like that. And they make sure they balance the calcium levels. They increase the blood calcium levels, right? Piaget's disease, what is that? It is a genetic disorder. And this could happen with overactive osteoclasts. Or what are osteoclasts? Bone cells that break the bone cells. Breakdown of the bones is faster, so the bones are weak, and they could cause severely deep bone pain, headaches, and hearing loss. So antihypocalcemic agents are teriparatide and parathyroidism, parathyroid hormone. Actions. They stimulate osteoclasts or bone cells to release calcium from the bones. So basically, they increase the bone breakdown. Increase the intestinal absorption of calcium. Increase the calcium reabsorption from kidneys. And stimulation of cells in the kidneys to produce calcitrol. Indications. Management of hypocalcemia in patients undergoing chronic renal dialysis and treatment of hypoparathyroidism. Pharmacokinetics. Absorbed from GI tract, widely distributed throughout the body, stored in the liver, fat, muscle, skin, and bones, and metabolized in liver, excreted in the urine. Antihypocalcemic agents. Contraindications are allergies to vitamin D, hypercalcemia, vitamin D toxicity, and pregnancy. Caution: with history of renal stones. Adverse effects, GI effects, CNS effects, drug-to-drug interactions, magnesium-containing antacids, cholestyramine, or mineral oil. Nursing consideration for patients receiving hypocalcemic agents. Always check for the baseline disorders. Check whether patient has any allergies. Check for any other allergies beforehand. Hypercalcemia, vitamin toxicity, renal stone, or pregnancy or lactation. Skin lesions, patient's neurostatus, alert, and orientation status. Liver evaluation. Serum calcium, magnesium, and alkaline phosphatase levels. And then radiographs of bones. Calcitrol. This is for management for hypocalcemia in the patient on chronic renal dialysis, management of hypocalcemia associated with hypoparathyroidism. Actions. Vitamin D compound that regulates the absorption of calcium and phosphate from the small intestines, mineral reabsorption in the bones, reabsorption of phosphate for renal tubules, and increasing serum calcium level. Adverse reactions: weakness, headache, nausea, vomiting, dry mouth, constipation, muscle pain, bone pain, and metallic taste. Hypercalcemic agents. Biphosphonates. These drugs act on the serum drug levels of calcium and not directly on the parathyroid gland. They slow the normal and abnormal bone reabsorption. Side effects include headache, nausea, and diarrhea. Now, calcitonin, hormone secreted by the thyroid gland to balance the parathyroid hormone. It inhibits the bone reabsorption. And side effects include flushing of face and hands. Antihypercalcemic agents include slow or they block the bone reabsorption, meaning they do not allow the bone to be slowing down of bone breakdown and slowing down of osteoclast activity. One of the most important ones to memorize is Fosamax or alendronate. There's specific instructions with biphosphonates. It blocks the bone reabsorption By doing this, they help to lower the serum calcium levels, and they do not inhibit the normal bone formation and mineralization. Calcitonin, they inhibit the bone reabsorption again, and they lower the serum calcium levels in children and in patients with Piaget's disease, and increases the excretion of phosphate, calcium, and sodium from kidney. Contraindications. When are they contraindicated? With hypocalcemia, with pregnancy, lactation, renal function abnormalities, and GI disease. Calcitonin also in pregnancy, renal dysfunction, or pernicious anemia. Adverse effects. What are the bad effects? They could cause headaches, nausea, diarrhea, bone pain, Piaget's disease. Calcitonin, flushing of face and hands. Then it could cause nausea, vomiting, urine frequency, and local inflammation at the site of injections. Drug-to-drug interactions. Drug-to-drug interactions, whenever we're giving them with antacid, calcium products, iron, multivitamin, aspirin, we just have to be making sure that we are consulting physician before we do that. Okay. Always check for allergies, check for baseline pregnancy or lactation status, history, hypocalcemia, renal dysfunction, skin lesions, orientation and affect, abdominal examination, serum electrolytes, renal function tests. Alendronate. What is something very, very important with alendronate is how do you give it? We usually have patients take it in the morning, 30 minutes before the meal, have them sit up, and then make sure we give them with 8 ounces of water. That is very specific instructions with alendronate. And remember, it is given for treatment of osteoporosis with postmenopausal women. And this is for treatment of glucocorticoid-induced osteoporosis, treatment of Piaget's disease in certain patients. All right. And so this is one of the most important ones. Usually treatment time, it takes a greater than 10 days. It doesn't work right away. It takes a little while. And it could give nausea, vomiting, diarrhea, headaches, and esophageal erosions. Another one is calcitonin salmon. Usually it is given for Piaget's disease and postmenopausal osteoporosis. Emergency treatment of hypercalcemia, inhibits the bone reabsorption, lowers the elevated serum calcium in children and patients with Piaget's disease, the excretion of filtered phosphate, calcium, and sodium by kidney. All right. Question. Piaget's disease is a genetically linked disorder. It is a condition involving overactive osteoclasts that are eventually replaced by enlarged and softened bone structures. What are clinical manifestations of Piaget's disease? Bone pain, increased hearing acuity, visual acuity, or cardiac dysrhythmias? Bone pain, because it's a bone disorder. All right. So this was chapter number 37. Now, let's do stop share here. Okay, before we go to the next one, we are going to discuss the next video is on insulin. I would say, like, let's say I don't understand this portion of my lecture, or I don't understand this word. You can Google those terms on the side and just see, okay, what does osteoclast mean? Osteoclast means this is just the fancy name for bone cells, which help in breakdown of the bones, right? So let's say if you are listening to the lecture and you're like, okay, I don't understand this, pause the video, go on Google, research that word, and then understand it, try to know the definition of it, and then replay it. So that's just a small little tip on, let's say if you get stuck in certain areas, like I don't understand this, I need to repeat this. So that's how you do it. You can, the best part in videos is you can replay it multiple times. But so that's something which I would say. Let's say if you don't, if something is just like, I don't understand this, let me just pause it real quick. Let me go on Google and just read on this, like read the definition of the word. If one of the words just kind of like, what is this? It's confusing. I don't understand this. So I highly recommend that you do that. Okay, next chapter is on insulin. All right, I'm going to do screen share. Okay, we are going to chapter number 38, which is technically the last chapter. All right, we are going to talk about blood glucose levels. We're going to talk about blood sugars and a condition called as diabetes. Okay. So pancreas, this is like a leaf-like structure that sits right underneath your stomach on the right side of your abdomen. It's like a little leaf, all right? It produces, what does it produce? It produces insulin and glucagon. So it's an endocrine gland. It produces hormones in the islets of Langerhans. Exocrine glands releases sodium bicarbonate, pancreatic enzymes into the common bile duct to release into small intestines. It neutralizes the acid chyme from the stomach and acid digestion. So it has two functions, endocrine and exocrine. But endocrine function is secretion of insulin and glucagon. Now, insulin is a hormone produced by beta cells of islets of Langerhans, released into circulation when the levels of glucose around these cells arise. Stimulate the glycogen synthesis, conversion of lipid into fat stored as adipose tissue, synthesis of protein from amino acids, and release from after meals, causing blood glucose levels to fall. Glucagon is released from alpha cells of islets of Langerhans in response to low blood sugar. So basically, there's like always those reversal hormones that will reverse the effects of, like, insulin's effects is reversed by glucagon. Glucagon will end up increasing the blood sugar. Insulin decreases the blood sugar, glucagon will increase the blood sugar. It causes immediate mobilization of glycogen stored in the liver and raises the blood sugar level. Okay, reversal, like it's like reverse this, right? That's what glycogen does. So glucose regulation is, what does it do? Adipocyte secretes adiponectin. This is a little too complicated, so we don't have to necessarily review all of it, but most important is the function of insulin. Insulin, as simple as that, will decrease the blood sugar levels. Glucagon increases the blood sugar level. Okay, now let's look at this slide. This slide talks about hyperglycemia. What is hyperglycemia? Hyperglycemia means high blood sugar levels. So patients who have diabetes have high blood sugar levels. Why? Because sometimes their body does not produce insulin, or if it produces insulin, the body just say, you know what, I don't like it. I know I have the insulin reserves, but I'm not gonna work with it. I don't like this. So that is diabetes type 2. When you do have insulin, but the body cells doesn't want to work with them, right? The receptors are non-functional. So that is type 1 and type 2 type of diabetes. Glycosuria, this is sugar spilled into urine. Polyphagia, increase hunger. Polydipsia, increase thirst. Lipolysis, fat breakdown. Ketosis, ketones cannot be removed effectively. Acidosis, liver cannot remove all the waste products. So there's 3 signs of diabetes. If someone has diabetes mellitus, they will have polyphagia, polydipsia, and polyuria. Polyphagia means they want to eat a lot. Polydipsia, they're thirsty. And the polyuria is they pee a lot. Those are 3 signs of diabetes mellitus, right? And diabetes means it's a condition of high blood sugar. It is related with patients who are not producing enough insulin, or if they're producing it, their receptors are not functional. So those are 2 types of diabetes mellitus. Okay, so characteristics. It's a complex disturbance in metabolism. It affects carbohydrates, fats, and proteins, primarily carbohydrates. Clinical signs. Hyperglycemia, blood sugar levels are greater than 126. Fasting blood sugar higher than 126. That's a high level. Glucoseuria means glucose in the urine, right? Generally not present. And if a person has very high amount of blood sugars, they might have really bad vision. It's called retinopathy. Nerves, they might have problems in their nerve cells, and difficulty in oxygen carrying capacity. That's called neuropathies. And nephropathy, they develop bad kidneys. Atherosclerosis, something that sticks in their vessels causing plaques in the blood vessels, is atherosclerosis. So those are all disorders associated with diabetes. Type 1, so we talk about type 1 and type 2. Remember, type 1 is seen in younger people and usually with viral destruction of beta cells of pancreas where it's not producing enough insulin. Type 2, non-insulin dependent diabetes mellitus, usually occurs in mature adults, has slow and progressive onset. When person has high blood sugars, they feel tired, lethargy, irritation, glycosuria, meaning they have sugar in the urine, polyphagia, they want to eat a lot, polydipsia, they pee a lot, no, they drink a lot of water, and then peeing a lot is when polyuria. Itchy skin, they have dry, itchy skin. Like, why am I so itchy? Well, might have high sugars. Okay, signs, symptoms, impending dangerous complication of hyperglycemia. If someone runs really high blood sugar for a long time, they might have something called as ketoacidosis, which is how do we know? They have fruity breath. So if you smell at their breath like it's like a fruity odor, and that is because excessive amount of ketones that is developed in their body because of high blood sugars. They feel severely dehydrated. Something called as Kussmaul's respiration is a sign of ketoacidosis, which is deep respirations related with high amount of blood sugar, and loss of alertness and orientation status. So they're like confused and they feel they might go into coma. Hypoglycemia. Hypoglycemia is when patient's blood sugar is less than 70 milligram per deciliter. What's your normal blood sugar? Approximately 120, 100. It should be like above 70 and goes up to 120 to 140. Above 140 is blood sugar, high blood sugar, and less than 70 is low blood sugar. Okay, so whenever you check blood sugars, you should know that that's the range of blood sugar. So hypoglycemia means low blood sugar. Initial response to parasympathetic stimulation followed by fight and flight response. So whenever there's, let's say you have to do something like you have to get up and move around, usually your body will use all your blood sugar and then use it to produce energy, and then it causes hypoglycemia. Means your sugar level goes down because all of it is used. What is the following clinical manifestation of hyperglycemia? Is it edema? Is it lack of thirst? Is it itchy skin or hyperexcitability? Itchy skin, when a person is super itchy, it could be a sign of hyperglycemia. Okay, actions of insulin. Insulin, what does it do? It's a hormone that is produced by where? Pancreas and beta cells of pancreas. It facilitates what? It will cause the blood sugar levels to go down, right? Insulin indications. When do we give insulin to our patients? It comes in as a medication form, right? We give it when a patient has type 1 diabetes, type 2 diabetes in the patients, which cannot be controlled by diet or other agents. So synthetic insulins. Various insulins are available in processing, so there are different kinds of insulins that are available. When do you not give them? Not necessarily any contraindications. We want to make sure we check patients' blood sugar levels before we give insulin, pregnancy, lactation, and we check for sugar levels. They should not have severely high blood sugars or any ketoacidosis. We check for that. All right. Whenever we give insulin, we want to make sure that they are not having any asthma, COPD, skin lesions, or we check for vital signs and their neurostatus, whether they're alert and oriented. What is their baseline blood sugar checks? Okay, this slide I have it in further areas. We're gonna go there in a second. Now, sometimes we give them insulin injections, sometimes we give them tablets, which will help their blood sugar to go down. So the medications that will decrease the blood sugars, they come under something called as sulfonylureas. It's a fancy name for medications for high blood sugar disorders, right? So first generation sulfonylureas are tolbutamide, and it's very commonly used. Then chlorpromamide. Second generation glimepiride, glipizide, and glyburide, commonly used medications, very commonly used medications. So what are they associated with? They could be associated with cardiovascular diseases. Second generation, we want to make sure that we They're all of these medications, remember, they are metabolized in liver, excreted in the urine. So we check for liver function, kidney function tests before we give it to them. Actions: they stimulate insulin release from the beta cells in the pancreas, and they improve the binding to insulin receptors. So sometimes insulin is there, they will help this insulin to bind to the receptors, like, okay, let's connect, well, how come you're there and your receptor's there, insulin's there, you're not connected, you need to connect to each other. So sometimes they will produce that connection. So that's sulfonylureas. Indications: adjunct to diet, exercise. So whenever a person has high blood sugar problems, we tell them to regularly eat low carbohydrate diet, exercise every day, 30 minutes to 1 hour. That will just help their body to function better and metabolize their blood sugars and produce insulin in a better form. Okay, pharmacokinetics. For sulfonylurea, they're absorbed from the GI tract. They undergo hepatic metabolism, excreted in the urine. We check for allergies. We check for any complications, baseline complications. We check for hypoglycemia, which is because we are giving a medication to lower down the sugars. Patient might go into hypoglycemia. Signs of hypoglycemia is when you're super hungry. Think about, you were very hungry after playing a basketball game with your friends, and you were like, or you went for a run and then you came back and you're like, oh my god, I'm so hungry and I'm so thirsty. So you feel shaky, you feel tired, you feel like weak. All of those are signs of hypoglycemia. GI distress, adverse effects could be GI distress. So that's how a person could feel when they take these medications, because they will bring their blood sugars down. Allergic skin reactions, they might give allergies. Drug-to-drug interactions, drugs that acidify urine, and then beta blockers and alcohol. Chlorbromide is one of the medications which we give. And then glyburide, we talked about, those are just our sulfonylureas. Question: second generation sulfonylureas have several advantages over first generation sulfonylureas, including the fact that they interact with more protein bound drugs. False. Second generation sulfonylureas advantage over first generation drugs would be they are excreted in the urine or bile. They do not interact with as many protein bound drugs, longer duration of action. Okay, other anti-diabetic agents. What are the other anti-diabetic agents? There are other medications. We always check for kidney function and renal function test. We always do urine analysis. One of the most common drug we use is metformin. Metformin, because it works through kidneys, we always check for kidney function test before we give metformin. Whenever we are giving metformin to the patient, if a patient is going for, let's say patient's going for IV dye induction, so meaning, like, let's say going for angiogram and they will induce an IV dye, we will hold metformin 72 hours before giving that dye. Why? Because that dye is bad for kidneys and metformin is also bad for kidneys. They both combine and they could cause kidney problems. That's why we hold metformin a good 2 to 3 days before, which is 48 hours before giving that dye. Any kind of dye injection, we hold metformin 72 hours, 48 to 72 hours before. Okay, we check for, let's say we want to raise our blood sugar, patients having really low blood sugar and we have to increase their blood sugar. So there's something called synthetic glucagon, and that is available. Sometimes we give them sugary, like drink apple juice, or give them like 8 ounces of milk, or protein if they're gluten oriented, or sometimes glucagon or 50% dextrose to increase their blood sugar because their blood sugar is dropping. So then we will just give them high amount of medications that will increase their blood sugar. It increases the blood sugar. This is treatment for hypoglycemia that are rapidly absorbed or distributed throughout the body and excreted in the urine. Contraindicated. When are they contraindicated? Remember, allergies, pregnancy and lactation, hepatic dysfunction, adverse effects, GI, vascular effects, drug-to-drug interactions, thiazide diuretics, and anticoagulants. Assess. Check. Check for history, physical, check for allergies, check for liver function, kidney function tests before you give medication check for baseline blood sugar levels. Which of the following is a primary action of glucose lowering agent? Do they accelerate the breakdown of glycogen? Do they increase insulin release, improve binding to insulin receptors? They decrease the use of incretin. They will accelerate the breakdown of glycogen. Now these are the sites where we give insulin injections. So there are some synthetic injections. They could be given subcutaneously on the arm or on the belly fat or in the front of the thigh. Okay. Insulin injection sites could be just on the fat layer. If a person's really skinny, there's time we have to just squeeze the fat subcutaneous and then give the injection. Upper thigh is the best area. Abdomen is a really good area, and upper arms. All right. Insulin injection kind of looks like this. This is Humalog injection. These are just this very skinny needles, right? We use that, and then these are Humalog pens. So we could use those. Insulin are different types. So rapid acting insulin are they are named as Humalog, Novolog, and Epidra. Their onset is let's say a person got a shot of insulin, rapid acting insulin, Humalog. It will work for 10 to 30 minutes, and then it will peak maximum effect in 30 minutes to 3 hours. And how long does it stay in the system? Only for 3 to 6 hours. It says 5 hours, usually not more than 6 hours. So it usually comes out of the system after 6 hours. They would need another shot because that's how long it lasts. Short-acting insulin is regular insulin. If you give a shot of, let's say, 10 units of regular insulin, it will start working in 10 minutes. It will be good. It will peak. It will have maximum effect in your system 2 to 5 hours, and it will stay in the body system for 12 hours. Intermediate acting is also NPG or insulin N. It might start working in hour and a half to 4 hours. It peaks in 4 to 12 hours, and it stays in the system for 24 hours, body system for 24 hours. Long-acting insulin, also called as Lantus or Levemir, it will start working in 4 hours, like approximately 1 to 4 hours. It peaks approximately 6 hours to 12 hours, and then it stays in the body for 24 hours. So these are just the actions, onset, peak, and duration. Some questions will ask you, if you're giving Humalog to your patient, when will it peak? So you say, oh, it peaks in approximately 30 minutes to 3 hours. You're giving regular insulin. When would it peak? It will peak in 2 to 5 hours. Now, insulin can come in a pump form. So usually there's a needle that's inserted in the belly, and there's a small little bottle over here, and there's an injection that will just slowly suck that medication, and through this small little pipe it will constantly deliver like 1 drop in 1 hour. So usually this is set up by a doctor, a physician's office, and a person doesn't have to give themselves shots every 6 hours or every 12 hours or every once a day. It will constantly deliver that medication like an 1 ml per hour, or so it slowly absorbs, so the person doesn't have to poke themselves constantly. And it looks like, look at this, the needle goes in there, and then it constantly gives the insulin to the subcutaneous fat. It gets absorbed from there. This is another chart for pharmacokinetics for different kinds of insulin. So it says regular insulin, Novolin, or Himalin. It starts functioning in 30 minutes. It peaks in 2 to 4 hours, stays in your body for 6 to 8 hours, and usually we give it to the patients 30 minutes before eating. Okay, and then rapid acting. There's some rapid acting, like really fast acting, Novolog, Humalog, and Epidra, and they start working in less than 15 minutes. They're good for they peak in 1 to 3 hours, and then their duration usually not more than 5 to 6 hours. After 4 hours or 5 hours, you have to give another shot. So that's their function, right? So that was pretty much it about when we were talking about insulins, and we also talked about thyroid hormone. It is this is approximately 40 minutes video, so I think it's a good time to take a little break. I will do video number 3, which is technically reviewing the PowerPoint slides, which is from Dr. Lee. Okay. So I will see you in video number 3 now. Take a 15 minutes break.